Today is March 13th, 2020, and this is a presentation to increase the public and physicians' awareness of COVID-19 coronavirus infection. This is Mazen Kerallah, an infectious disease and critical care physician at Sanford Health System, University of North Dakota. The situation is dynamic. What we know today may not be accurate next week. The aim is to deliver facts that will decrease inflammation and increase information. This information will help in developing individual and community strategies to fight and contain the pandemic. The outline of the talk will start with the virus itself, and then we'll talk about the pandemic, the transmission dynamics, the illness, and then we'll end up with prevention. So what's about the virus? There have been a number of human infections caused by coronaviruses such as 229E, OC43, NL63, and HKU1. The disease that is caused by this virus is a mild upper respiratory tract infection such as common cold. This is true though till the early 2003, when a severe acute respiratory disease caused by a new coronavirus appeared in the community and was thought to be transmitted from the civet cats in China. Several years ago, specifically in 2012, another coronavirus appeared in Saudi Arabia, the MERS coronavirus, which was thought to be transmitted from camels to people and caused an even more severe disease which carried a higher mortality rate. So this is our third coronavirus, and like the other coronaviruses, it appears to be primarily an animal virus. And this virus has been transmitted from animals to people. This one, like the others, likely originated in pets and may have been transmitted through an intermediate animal vector that is not identified yet but thought to be the pangolin. These coronaviruses likely circulate in an animal reservoirs, with the pat being a well-described natural host, and through an intermediate animal species can intermittently jump into human and cause infections. In case of SARS, it was the civet cat. In case of MERS, it was the camel. And now we think it is the pangolin. When exactly this phenomena happened is not clear, but we think it is suspected that it happened in December 2019 and was associated with wet market interactions where a lot of animals are present and human interactions with them took place. So this is to compare the three outbreaks. The SARS outbreak in 2003 started in China and spread to 29 other countries, caused a total of 774 deaths out of 8,096 cases. With a case fatality rate of 9.6, it was contained on July 5th, 2003. The MERS 2012 caused so far 858 deaths out of total cases of 2,494 cases, started in Saudi Arabia and spread to 27 other countries, with a case fatality rate much higher than the SARS at almost 35%. MERS remains present at low levels. However, aside from certain super spreading events, it is not transmitted terribly efficiently. The current pandemic started in China and spread to more than 116 other countries, with total of deaths so far being around 4,700 deaths, a case fatality ratio around 3.3 to 3.5%. So in order to understand the pandemic, we need to go through the epidemiological curve. And this is applicable for any outbreak where it starts with the initiation case, where you can see cases here and there before it gets to a critical point where it accelerates exponentially and the number of cases will increase to reach the peak of the pandemic or the outbreak, and then starts to decline as the outbreak is contained. The virus may circulate in the community at a low level after the outbreak, or it may actually be completely eliminated. So this is the epidemiologic curve for the outbreak as it was on February 20th in China. And you can see how the epidemic peaked few weeks after the start and then declined rapidly with all the strict community interventions throughout the province of Hubei and in the rest of China. Following that, we started seeing cases in the rest of the world, in Europe and in Asia, and now we see cases in the Americas. And the epidemiologic curve is in the acceleration phase, and you can see the increased number of cases. This is as of March 2nd, 2020. As of yesterday, on March 12th, total number of confirmed cases 127,863, with total deaths of 4,718. The case fatality ratio is taken by dividing the number of deaths by the total confirmed cases. So if you calculate it, it would be around 3.5%, but this number is a dynamic number for two reasons. Number one, we don't know how many of those confirmed cases throughout the disease will end up with death, and that the number will be actually higher and the rate will be higher. This is what happened with SARS 2003. Initially, the mortality rate was around 4%. By the end of the outbreak, it increased to around 10%. On the other hand, this is the total confirmed number of cases. If we have much more in the community that they are not confirmed yet, and as the pandemic goes on, we confirm those cases and turn out those cases are mild cases, they don't end up with mortality. At that time, the number of deaths divided by the total number of confirmed cases will give us a lower mortality rate. But we think it is above 2% so far. We'll see how things will unfold with this pandemic. First case in the United States was reported and published in the New England Journal of Medicine. It's reported in the state of Washington in a 35-year-old patient who arrived from Wuhan a few days earlier. The illness started with cough and followed by fever and fatigue. But he had other symptoms too, with nausea, vomiting, diarrhea, abdominal discomfort, and rhinorrhea. It was diagnosed on January 20th. The chest X-ray shows that he has early infiltrate in the right lower lobe, and we know now that this infection causes lower respiratory tract infection as it attaches to the angiotensin converting enzyme receptors in the lower respiratory tract, and that's why most of those patients had evidence on chest X-ray or CT scans of lower respiratory tract infection, mainly bilateral pulmonary infiltrates, interstitial pattern. But it could be any of the infiltrates, could be patchy infiltrates or focal infiltrates. In the States, as of the 29th of February, we had only 68 confirmed cases with one death. A few days later, on the 5th of March, that number of confirmed cases increased to 221, with total number of deaths increased to 12. Only 2 days later, the number doubled to 400, with total number of deaths of 17. That tells you now the virus is circulating in the community, and as we are scaling up testing, we're confirming more and more cases. On March 10th, the number doubled to 755 with total number of deaths 26. And as of yesterday, we had 1,323 cases with total number of deaths of 38 cases in all the states. Now we see the disease in almost every single state except for few. And we need to assess the pandemic severity index. We need to see how severe this pandemic is. And we go with the mortality rate or the case fatality ratio. So we have 5 categories that goes from 1 to 5 based on the case fatality ratio. For less than 0.1, it's category 1. As the case fatality ratio goes up, we go to category 2, 3, 4, and 5. Since our mortality rate appears to be above 2%, that means we're in category 5. And that means if we have an attack rate of 30% in a US population in 2006, the estimated number of deaths would exceed 1,800,000. But with the measurements interventions, we hope the attack rate would be much lower than this. Now, a new pandemic severity assessment framework has been applied for influenza specifically, and that will rely on 2 factors. Number 1 is what is the clinical severity, and number 2, what is the transmissibility. So we can divide the assessment framework into 4 quadrants. Low severity, low transmissibility. This is what happened in the influenza 2006-2007, for example. The influenza 2009 H1N1 was on the border between the low and higher transmissibility, but it was low in severity. The Spanish influenza in 1918 was high in severity, high in transmissibility. So in order to understand this, we need to understand what are the parameters to determine transmissibility and clinical severity. And this is actually applicable for influenza specifically. We're extrapolating this and comparing this data with our coronavirus, with this pandemic. So we need to know the attack rate in the community, which we don't know yet for coronavirus. And you can see that it is graded from 1 to 5 based on this attack rate of less than 10% all the way to above 25% in the community. And then we look at the symptomatic attack rate in the school and the attack rate in the workplace and the household secondary attack rate from less than 5% to more than 21%. And then we look at the basic reproductive number, which I'm going to explain later. And this number is known now with the coronavirus of being above 1.8. It is specifically 2.2 to 2.5. The peak percentage of outpatient visits of influenza, also another parameter that is used to determine transmissibility. In terms of severity, we go with a case fatality ratio, and we already determined that our case fatality ratio is looking to be more than 2%. Case hospitalization ratio, number of hospitalization of all confirmed cases. We know that we are hospitalizing more than 20% or about 20%. The ratio between deaths and hospitalization, it looks like it is in the range of 16 to 18. If we apply this, that means if we need to compare the coronavirus with the other influenza pandemics or epidemics, At that time, it would be high severity, and transmissibility may actually be ranging in the mid-level. We don't know if it is higher or lower. So how are we going to mitigate this pandemic? It's actually, if we look at the epidemiologic curve, the intention would be one of the three. Number one, we need to delay the acceleration as much as possible. And number two, we need to reduce the peak number of cases to decrease the demands on the hospitals and the infrastructure. And number three, we need to prolong the pandemic as much as possible so we can decrease the number of cases admitted to the hospital to be able to care for those patients within the capacity of our healthcare system. So if this is the capacity of the healthcare system, anything above that would be actually overwhelming to the healthcare system, and we probably would not be able to care for them effectively. So from understanding the pandemic to understanding the transmission dynamics of the virus, we know for sure that there is person-to-person spread. And we know that the initial cases originated from animals. It is a species jump. However, now the virus is spread between people who are in close contact with one another, and that is within about 6 feet. It gets transmitted through respiratory droplets produced when an infected person coughs or sneezes. Also, we know that this virus is spread through contact with infected surfaces or objects. This happens by touching the object or surface and then touch the mouth, eye, or nose. Also, we know that in special conditions, this virus may be airborne. Those conditions happen mainly in the hospital with special procedures such as bronchoscopy, tracheostomy, intubation, non-invasive mechanical ventilation, and other procedures that can generate aerosols. Now, the spread is related to number one type of the virus, the clinical syndrome it is caused by the virus, and then the individual behavior or the community culture in practices such as kissing, hugging, or other close contacts. So when is the patient contagious? Is it only when the patient is ill? Now we know that the virus is isolated from respiratory secretions, from the blood, and from the stool. So theoretically, there's a possibility of fecal transmission at the same time. So is the patient contagious only when he's sick, or even if the patient in the incubation time or period? We know that the disease starts with the incubation of 1 to 14 days and then causes the infection, which could be mild, moderate, or severe. Duration could actually go up to 8 weeks before the patient recovers. The other thing which we don't know is, do all people have the same degree of shedding? Are those patients with severe disease have higher rate of shedding compared to the mild or moderate disease? And are patients still contagious in the convalescence period? What about pregnancy and lactation? We don't have data about that, but we extrapolate data from the other coronaviruses that we know. And in MERS and SARS, we did not confirm vertical transmission of the virus to the fetus, and no transmission through lactation. And then we have the super spreader phenomena that we've seen in SARS and MERS. Is it present in coronavirus COVID-19? We don't know yet. What we know is that the virus may be transmitting even in the incubation period before the patient is showing symptoms. And this is confirmed with the publication in the New England Journal of Medicine just, I think, yesterday or the day before. In a patient who contracted the virus, a German patient contracted the virus from a woman who visited Germany for a business trip. And patient 2 also contracted the virus from contact in the same meeting. You can see that we have patient 3 and patient 4. These two patients did not attend the meeting. However, they had contact with patient 1 and patient 2. And you can see that contact occurred even before these two patients showed any symptoms. So we have evidence that we can transmit the virus even before the patient is showing any symptoms. And this is actually a problem because now we may be having patients walking around in the community spreading the virus to other people. And then the spreading is mainly droplet. And what we mean by droplet is that those droplets that actually formed with sneezing, coughing, if they have a size of more than 100 micron, they may actually fall within 1 or 2 feet. With the size of more than 10 micron, they may actually drop within 2 to 3 feet. However, if we have the phenomena of infectious droplet nuclei, where the water of the droplets is evaporating and leaving this very contagious viruses in the air, the size would be less than 10 micron, and then those will be airborne, and that's why we are concerned about some aerosol producing procedures, and then the transmission would be airborne. So the main transmission would be for the coronavirus is droplet in the community, and in special conditions we are concerned about some airborne transmission. Now the other thing that we need to understand is the basic reproductive number, which is the R naught, which means how many patients would be infected from a single case. So if the R naught is 2, that means one case will infect 2 others. As this number goes up, that means more patients will be infected. R18 means that 18 other people will be infected from a single case. This is some examples where measles is associated with R18, and that's why it is very contagious, compared to Ebola virus is R2, R02, and that means it infects 2 other people with every single case. In our coronavirus COVID-19, it's estimated to be at 2.2, meaning that maybe 2.52, meaning that every single case can infect around 2.5 people around it. The virus is inactivated on surfaces, but it may take few hours to days. It depends on the type of the surface, the materials, and the temperature. At least 3 hours will survive, but it may be longer than this. The virus can be easily inactivated by hydrogen peroxide, ethanol, and sodium hypochlorite. What is the clinical syndrome? We know that the incubation time is 1 to 14 days. The median was 5.2 days. We have a 95% confidence that it will be between 4 to 7 days. Symptoms start after that with fever, mainly fever, cough, myalgia, and shortness of breath. We see CT scan or X-ray findings in up to 86% of the cases. The diagnosis is mainly through obtaining nasopharyngeal and oropharyngeal swabs at the same time. We can do PCR on sputum or bronchoalveolar lavage. We know that 81% of the cases are mild to moderate. We have 14% of the cases are severe and 5% are critical. So almost 20% of patients would require to be hospitalized. More severe disease is seen in advanced age and chronic comorbidities, and we'll look at those conditions in the next slide. Mortality rate, as we talked about, it is a dynamic number at this point, but it is around 3.5% so far. So most of the symptoms are fever and a dry cough. Fever is seen in 88% of the cases. However, on initial presentation, you may not see fever in more than 50% of the cases. Fever develops as the disease is progressing. Dry cough in around 68% and fatigue around 40%. Sputum production was seen in 34%. Shortness of breath was around 19%. So the mortality rate based on the age group, unfortunately, we've seen the highest mortality rate in age group 80 years and above, approaching 15%. Age group between 70 and 79 is 8%, 3.6% in age group 60 to 69, and 1.3% 50 to 59. And then it goes down lower for the younger population. Those patients with chronic conditions such as cardiovascular diseases, congestive heart failure, for example, diabetes, chronic respiratory disease, COPDers, hypertension, cancer, immunosuppression, even chronic renal failure are associated with higher mortality, and you can see it's up to 10.5% in cardiovascular disease, 7.3% in diabetes, 6.3% in chronic respiratory disease, 6% in hypertension, and 5.6% in cancer. The mortality rate is less than 1% if there is no health condition associated. So what can we do to prevent the disease? So what if a person is not sick? What we should do is the following. Number one, keep away from others who are sick. Limit face-to-face contact with others as much as possible. Avoid unnecessary gathering, such as the subways, Friday's prayers, other gatherings such as theaters, cinemas, and big meetings. Avoid shaking hands, hugging, and kissing. And this is very common in our culture. Clean your hands often for 20 seconds with soap and water. You can also use alcohol-based solution, but has to be at least 60% and less than 95%. Cover cough and sneeze and avoid touching face with unwashed hands. It is not advised to wear a mask in the community unless someone is in close contact with sick patients. We need to make sure that we clean all high touch surfaces every day, such as keyboards, mouses, door handles, and similar surfaces. So the second category is those who are household members, intimate partners, or caregivers in a non-healthcare settings in suspected or confirmed cases. Number one, we need to monitor patients' symptoms. So that means if we're taking care of a relative, father, a spouse, or son, daughter, we monitor their symptoms and make sure that if the symptoms are progressing, we inform the physician. We need to stay in another room and use a separate bathroom so we don't get in contact with surfaces that are used by the patient. Do not allow visitors. Make sure that you ventilate the shared areas very well. We need to continue to clean our hands as often as possible for 20 seconds with soap and warm water or alcohol-based solution. Avoid touching eyes, nose, and mouth with unwashed hands. If we get close to the patient, we need to wear face mask and gloves when we touch or have any close contact with the patient's secretions. Similarly, we need to clean all high touch surfaces every day, such as door handles, keyboards, mouses, or any other surfaces that are common to be touched. Avoid sharing household items with the patient and wash laundry thoroughly. If one of us gets sick, we should stay home except to get medical care. And if we need to get a medical care, we need to call ahead before visiting the office so we can alert the office of the possibility of COVID-19. So we don't go to the office and sit in the waiting room, contaminate everybody else with the cough and the sneeze. We need to separate ourselves from other people and animals in the home. If somebody is sick, should wear a face mask, cover the cough and the sneeze, clean hands often, avoid sharing personal household items, clean all high-touch surfaces every day, and again, monitor the symptoms. Symptoms may get worse and patients may be needing hospitalization. Just to emphasize about the cough etiquettes, we do need to use tissues or the sleeve or the side of the jacket, but make sure that if we use this, it is contaminated, it needs to be washed after that when you get home. And this is just to emphasize more about the appropriate way of coughing or washing hands. We need to make sure that we wash hands for 20 seconds to involve all the surfaces inside and outside, between fingers and at the knuckles, in addition to the nails. Trimming the nails would be advised also, so we can easily clean the fingers. In hospital settings, we're using negative pressure rooms with airborne precautions, putting N95. You need to get fitted. Make sure that it's sealing very well on your face. And also, we need to use goggles with those procedures and when we get into the room where the possibility of aerosol producing procedures is high, and I named some of those earlier: bronchoscopy, tracheostomy, intubation, nebulized treatment, high frequency ventilation if we ever use it again, and similar precautions, similar procedures. Of course, dental procedures are known to generate high level of aerosols. There's no specific treatment other than supportive care, prevention and management of complications, and we have some medications already on the shelf. We know that lopinavir, ritonavir may have an activity against coronavirus. We know this from the MERS coronavirus outbreak, and we probably going to see some studies about this. Chloroquine also may have some activity. Remdesivir is another agent that is actually studied in a trial. I think it's in Nebraska, and I'm not sure how long it's going to take before we can see results of this medication. In conclusion, please wash your hands frequently, avoid close contacts with others, do not touch your face with unwashed hands, avoid gathering, inform your primary care provider for any fever, cough, or shortness of breath, and thank you very much.